Hey colleagues, if you are a mental health professional but feel like you don't have an understanding of the basic medicines that are used to treat common mental illnesses, then listen up, because in this series we're diving deep into psychopharmacology for therapists. Welcome back to Psychopharmacology for Therapists. In this series, we're exploring the most common medications in mental health, with added therapist commentary to help mental health providers be more effective in their work. In this episode, we're discussing antidepressants. So let's start off by talking about antidepressants. And in this portion, we're going to talk a little bit about the history of antidepressants with some of the older ones that aren't used as much anymore, all the way to the modern ones that are prescribed for nearly everything. And we're also going to talk about some of the treatments used whenever we have treatment-resistant depression, where it's not responding to typical medications in any dose. Before we dive into the medications, we should probably pause for a second to check in and make sure that you are aware that there are different types of major depressive disorder. And these different types may require different medicines or different dosages because of the severity or some of the symptoms that go along with those. So just to recap, when we're talking about major depressive disorder, we have single episode and we also have recurring episodes. In those episodes, we can have three different types of severity: mild, moderate, or severe. And we can also describe the depression in partial or full remission. And even whenever somebody's depression is in remission of one type or another, that doesn't mean that they may discontinue their medicines. They may maintain those medicines in order to maintain some form of remission. It's also important to note that among these diagnoses for major depressive disorder, we can have specifiers like psychotic features, anxious distress, mixed features, and melancholic features. Again, all of these things can be factors in the medicines that are prescribed. So let's get started with the first antidepressants, monoamine oxidase inhibitors, or what I like to call MAOIs. I'm pretty sure nobody else on earth calls them MAOIs, but I do, and nobody has stopped me yet, so you have permission to do that until somebody criticizes you, at which time you should stop and pretend I never told you to do this, and definitely don't throw me under the bus and tell anybody that I told you to say this. Anyway, these were discovered by accident in the 1950s from a tuberculosis drug that physicians discovered was improving people's mood and helping with some of the stubborn features of depression that often go along with chronic illness. They synthesized the medicine and discovered that it was inhibiting a particular compound called monoamine oxidase. And so they realized, hey, maybe if we can continue to block monoamine oxidase in the brain, that will help people's symptoms of depression. And it did, and it had worked for a while, and we still have them today. But today they're not used very commonly, and that's because they do have really dangerous side effects that can affect your cardiovascular system. And these are so sensitive that people actually have to be really careful what they eat and drink because some of those dietary things can provoke these side effects and put them in real danger. Now, as we go through this presentation, we're going to practice saying all these pharmacy words because we want to be competent therapists. Now look, I'm not some etymologist here. I don't know exactly how to pronounce every single word ever. I have a little bit more experience saying these words, and I tend to get lucky when I sound them out. But I want you to practice saying them because I want you to be seen as a competent professional who's familiar with these words and familiar with these medicines, and it comes through in the way you discuss them. So let's practice together. The first common MAOI is called phenelzine, and its brand name is Nardil. When you see things in parentheses, basically I'm just showing you that that's how it's marketed to the public. That's the name it's sold under. But the word that's not in parentheses is basically the way it's referred to in chemistry. The second very common MAOI is called, let's try it together, tranylcypromine, also called Parnate. Now, I also should point out that there have been some adjustments, and there's now a different type of MAOI offered, which are referred to as MAOBs. And this one in particular is called selagiline. I think I nailed that. And it's marketed under Deprenyl and Ensam. So now let's talk about the next generation of antidepressants, tricyclic antidepressants. So these two were sort of discovered by accident. They were adapted from an antipsychotic called imipramine in the early 1960s. Now, these were important as a discovery because they are quite a bit safer than those Mauis we talked about a moment ago, but they do still have some powerful side effects, and one of their downsides is they can be lethal if you overdose on them. Now, tricyclics or TCAs are still used today. They are relatively common. They're not usually the first choice, but they are a medicine that will be reached for by some physicians given certain situations. Let's practice saying all these fun words. Amitriptyline, clomipramine, desipramine, doxepin. By the way, I do see doxepin prescribed quite a bit. Imipramine, that was that original one from the 1960s. Oh, this one's fun. Nortriptyline and trazodone. Trazodone is another one as a therapist that I see prescribed quite a bit, usually used as some kind of sedative, especially for nightmares. All right, now we're going to talk about the new kid on the block, selective serotonin reuptake inhibitors, or SSRIs. Now, this is going to be the most common medicine that you're going to see your patients have, and it's a very good medicine overall. Not only is it new, but it doesn't have those dangerous side effects that tricyclics have or Mauis have, and it is less dangerous to overdose on, which makes it important because obviously depressed patients could potentially have a risk factor in that department. Now, it's considered a cleaner medicine, and what that means is that it kind of just does its job, whereas tricyclics sort of scattershot their medicine all over the place and can affect a number of other areas of your brain. SSRIs are very, very specific, and so for that reason, we consider them clean. They just kind of do their job. They do still have side effects, and they can have a range of side effects. Sexual dysfunction is one of the ones that your patients might complain about most. They might notice that they have a loss of libido or difficulty in ejaculation. Now, I want to take a beat to explain to you how I teach patients how SSRIs work, because again, one of our primary functions as therapists is to educate the patient. The way that I like to explain it is I tell them that we have these little dripping water faucets in our brain, and they drip these things called neurotransmitters, the juices that flow through our brain. One of those neurotransmitters is called serotonin, and what this medicine does is it inhibits the reuptake of the serotonin. So it basically clogs the drain at the bottom of the sink so that whenever we drip the serotonin, it builds up and builds up and builds up. So our brain gets more of its own juice. And that's what's special about SSRIs. They're not adding something to your brain. They're just allowing your brain to marinate in its own serotonin for longer before it drains away. And this is also such a gentle medicine that it takes a while to work. This is part of my pitch, how I explain it to patients, is that it almost is taking little pieces of paper and tossing them in the sink one by one and allowing that to slowly clog the drain. So it can take 2 to 4 weeks for that drain to clog sufficiently before you really start to notice a result. For this reason, though, it's a very gentle medicine. It's very reliable. We have decades of research telling us that they're very effective, very few side effects, very few long-term side effects. And of course, if you dig deep enough on the internet, you'll find somebody who had a bad experience and has a story to tell. But by and large, you can trust these medicines and they're very effective. Many of us call them the Tylenol of mental health because they are so common and considered to be pretty darn safe. So that's my pitch, and you're welcome to borrow that kind of language. Let's talk a little bit about some of the medicines that you're going to see. So here we go. We're going to try to pronounce these things. And all of these, by the way, are very common to see in the field. So fluoxetine, also called Prozac, citalopram, Celexa, escitalopram, Lexapro, fluvoxamine, feel like I nailed that, Luvox, I don't see that one very often, paroxetine, which is Paxil, and sertraline, which is Zoloft. Of the ones I just named, I tend to see Zoloft, Prozac, and Lexapro the most, Celexa second, paroxetine sometimes, and rarely, if ever, Luvox. So those SSRIs we talked about, we've actually developed into another area that kind of combines two different types of neurotransmitter reuptake inhibition. In this case, serotonin and also norepinephrine, just another neurotransmitter. So these are working the same way, right? They're still clogging the drain. They're just clogging two different drains at the same time. And they're really similar to SSRIs when it comes to side effects, though sometimes they can be a little bit worse. Again, not dangerous, just uncomfortable. Now, SNRIs are not typically prescribed right away. They're usually used secondarily after SSRIs have been ineffective, or if we have more severe cases because we want to throw a little bit more at them. So let's practice saying some of the common names of these medicines. Again, all of these I have seen in the field, and some of them a little bit more often than others. So venlafaxine, also called Effexor, that one's really common. Desvenlafaxine, also called Pristiq, again pretty common. Duloxetine, called Cymbalta, very common. Luvomilnacipran, also called Fetzima, I rarely see that one. And mirtazapine, also called Remeron, slightly more common, but not as common as Effexor and Cymbalta and Pristiq. So we've talked about serotonin reuptake inhibitors. We've talked about serotonin and norepinephrine reuptake inhibitors. And you're probably wondering, how come they have to be combined? Well, they don't. There is just norepinephrine reuptake inhibitors, or NRIs. And again, using that metaphor, they clog the norepinephrine sink, so just one of the neurotransmitters. Now, these do have different effects in the body, and usually they are used as an ADHD medication, but they can be used off-label for depression. These have a little bit of a different response in the body. They tend to improve people's energy, their ability to focus, but they also can kind of be triggering. They can cause anxiety. You might see that loss of appetite, sexual dysfunction, or paradoxically, sedation. So let's practice saying the one that's in America, atomoxetine or Strattera, and there's also one commonly used in Europe but not yet approved in America, reboxetine or Vestra. You will usually see Strattera, but again, it's not terribly common because usually people are going to use those SSRIs or SNRIs, and rarely are we going to end up using Strattera. So as science has progressed, we now have new classes of medicines that don't quite fit into any box, and we refer to these as atypical antidepressants. So one of the most common ones is what's called bupropion, or Wellbutrin is how it's marketed. Now this one's different. It doesn't function the same way with clogging that whole sink situation. Instead of clogging something or inhibiting something, it's increasing a different kind of thing in the body. A word that I always struggle with, but we're going to try it anyway. It's noradrenergic activity and dopaminergic activity. So what energic means is that it is somehow affecting whatever you saw at the beginning of that word. So dopaminergic means that it's affecting dopamine. And anytime you're increasing dopamine, you're usually creating stimulation. So bupropion has that effect. So it can also have those common effects of stimulants like anxiety, insomnia, but it is not a stimulant, just to be clear. And it does also augment SSRIs, which is kind of neat because it can actually neutralize their side effects. So sometimes what you'll see is somebody that's been taking SSRIs for a while and they're not having the effects that we want, and the physician says, I don't want to keep just increasing your dose. Let's go ahead and partner that medicine up with Wellbutrin and let's see if that can boost the effect. And it often does, which is a really great tool. And another medicine that we see in this atypical category is what's called buspirone or Buspar. And this is neat because it's an anti-anxiety medicine, but it can be used like Wellbutrin is to augment the power of those SSRIs. More atypical antidepressants to mention is vilazodone or Vybrid. Now Vybrid's different because it is an SSRI, but it also has a different mechanism, which is called a 5-HT1A receptor partial agonist. And what does that do? Well, it's a particular receptor in your neurons that are responsible for neuromodulation. Again, I promised you we're not getting into the chemistry because we're not here to get a degree in that. We're here to have basic understandings of these things. But what you need to know is that it can be used to co-treat anxiety, and so it can be pretty effective. But it is a version of an SSRI, so it's also used as an antidepressant. Another one that you'll see is Trintellix or Vortioxetine. I think I nailed that. This is also an SSRI, but again, it's not just an SSRI, it's a hybrid. And this one's also dopaminergic, which again has to do with the effects of dopamine in the system. So it's kind of combining, not necessarily inhibiting dopamine, but combining the stifling of serotonin with the increase of dopamine. And that can have really great effects. It can stimulate against low energy and apathy and be a really great supplement for depression. So let's talk about stimulants. Now, look, I have some strong opinions about this because we live in an era where anybody who can get their hands on amphetamines seems to get their hands on amphetamines. And I don't know that that's great for mental health overall, and I don't love it as a primary treatment for depression. So usually you're going to see doctors prescribe all the things we've talked about previous to this slide before they land on stimulants, unless somebody comes in and really tells the doc, this is what I want. But what do stimulants do? Well, most of you are aware that they increase energy, they have a general ability to improve your affect, and you might feel a little bit motivated. And so a lot of people seem to feel like they're getting more momentum in life when they're on them. And it is important to note that stimulants can do what we saw Buspar do and Wellbutrin do, which is augment other antidepressants. They do have side effects, and those need to be noted because a lot of people think that they're completely harmless. They are not. They can cause anxiety, insomnia, agitation, appetite suppression, which a lot of your patients will say, good, I've been gaining weight on depression anyway, so this will help me. But it is important to recognize that they are addictive. They are a narcotic. And so they are habit forming and they can become easy to abuse because they also induce euphoria. And that can cause people to become addicted to how good it feels. So they're usually contraindicated for anybody that has any history of alcohol abuse or narcotic use. And that can be difficult because those same people are not exactly going to admit that when they really, really want this medicine. So here are two of the most common ones. You've got dextroamphetamine, also marketed as Dexedrine, and methylphenidate, which is marketed as Ritalin. Now again, word of caution, don't recommend these. You are here to educate, refer, and monitor. Let people do their job. If your physician who's working alongside you or the psychiatrist is giving these medicines to a patient who you know has a tendency to abuse narcotics or alcohol or a history of addiction, you might want to ask for permission from the patient to collaborate with the physician so that you can make them aware of that. Because oftentimes these doctors are treated like vending machines. Patients just show up, push buttons, and get their candy, and we want to make sure that the patient's well taken care of. So sometimes medicines don't work, and the patient's experiencing what we often refer to as treatment-resistant depression. So when that happens, there are some options that people might use in those situations. One of them comes from like sci-fi and horror fiction films, electroconvulsive therapy. Unfortunately, the media has made this out to be something terrifying because in its early discovery, it was something kind of terrifying. So it was discovered in the 1930s, and what we saw was that epileptic patients who were having seizures would sometimes have decreased symptoms of depression after their attack. So the idea came out, what if we just induce an electric shock into this person's brain, and would that cause kind of a reboot and change their experience of depression? So it was used to induce a grand mal seizure, and that can be done, especially if we put the patient under with anesthesia to make sure they don't hurt themselves and we can keep them strapped down during the seizure. It can be done correctly and ethically. Today, believe it or not, ECT is considered the gold standard in effectiveness. Its side effects are actually quite rare, but it is still considered a treatment of last resort, obviously because we're inducing a seizure in your brain, and that's a pretty big step. But it is very effective. So another treatment-resistant alternative is what's called transcranial magnetic stimulation, or TMS. And it's kind of been taking the world by storm. It's showing up in every neighborhood. It has a lot of promise to it. And a lot of people like it because they don't have to take any medicine. They can just kind of do this outpatient treatment really quickly and hopefully get some results. So how does it work? Well, basically you sit in a chair, you put on this magnetic hat, and these magnetic coils send external pulses to areas of the brain associated with depression. So they're not doing what ECT does in that invasive sense or trying to trigger a seizure. They're very lightly pulsating from the outside, so there's no invasive procedure done, that's trying to just stimulate portions of the brain that we associate with depression. Usually treatments are really quick. They're 20-minute procedures. You do them just by driving over and stopping by. You're in and out, but you do have to do them daily for multiple weeks, sometimes up to a month. Now, here's a word of caution. Yes, TMS is scientifically validated. Yes, it can actually be used. But there's a lot of shadiness in the market right now. A lot of the providers are over-promising and under-delivering. They're making it a snake oil cure that can do everything. And the truth is it is quite expensive. Insurance doesn't always cover it. And a lot of these providers are kind of shady. And they just say, yep, you just got to keep doing it forever and ever, amen. When really, I think it's best used as a treatment-resistant alternative when the typical treatments of medicine and psychotherapy aren't getting us the results that we want to see. A couple of other treatment-resistant alternatives to mention that are not used terribly commonly, but do exist. The first one, vagus nerve stimulation. In this case, they actually implant a device into the chest of the patient, and it has a wire which stimulates the vagus nerve system. So there's a lot of neat evidence coming out about vagus nerve stimulation that shows that it can be effective on depression, but obviously implanting a device in somebody's chest is kind of a last resort. Another one is a treatment called deep brain stimulation, kind of the same thing, except in this case they're going to surgically implant a device into the skull, which stimulates portions of the brain with electric shock. Again, these are considered kind of extreme. They are not something that we do all the time. They are very unusual, and they usually only will be given to patients that are at high risk for suicide, seem to have permanent severe depression, and this becomes really the best option for them medically. So as we wrap up this conversation about treatment-resistant alternatives to depression, I want to talk a little bit about this little ditty, ketamine, and its derivative, S-ketamine. Now, these have been really popular in the media because they are high-power narcotics. They get you high, they give you euphoria, they help you dissociate from reality. And that's caused a lot of people to embrace them excitedly, believing that not only can curing depression be effective, but also lots of fun. And it's also led to a lot of dangerous deaths and a lot of bad outcomes with a lot of patients for many, many reasons, not the least of which is that when we overhype these things and underregulate them, we have people scoring them on the street or getting them wherever they can, taking them home, using them, and then dying from them because they are extremely powerful. Now, ketamine is usually delivered intravenously. It's an anesthetic. It's used to shut down pain and give you basically a euphoric high. And we do have research which shows that it can be effective for severe depression in the short term. Now, it's not necessarily more effective in the long term, but some people believe that it could be a really good tool for use in something like an emergency room if somebody was really near a suicidal action. Presently, as I record this, it is not FDA approved for use with depression. However, people use it off-label, and so a lot of doctors who can prescribe it, like veterinarians, have started prescribing it to humans for depression treatment when really it should be used for pain symptoms. Now, S-ketamine, a derivative, is delivered intranasally, so this is something that you'd snort, and it should be done, again, under medical monitoring, not something you take home. This one is FDA approved for depression. However, these medicines are costly, they are inconvenient, and often, at least in my city, are delivered by really shady providers who have popped up all over the place and don't seem very well regulated or very familiar with mental health overall. Generally speaking, these medicines offer short-term benefits. They have serious side effects like confusion, disorientation, hallucinations, and unusual thoughts. And again, while they do have value for severe cases that are treatment resistant, they are not something people should be recommended generally. Since we're talking about narcotics and how excited people are to use them, we should probably point out that there are some things that are not medicines and overhyped in the marketplace and on the internet. One of them, of course, is cannabis, marijuana. Where I live in Las Vegas, cannabis is completely legal. People use it recreationally, and a lot of states have adopted the use of it medicinally. And yes, there is some research that it can be effective for things like pain treatment and various other maladies, but it is not effective for chronic depression, and in fact, in my experience, usually makes patients worse overall as they do not develop coping skills, and we don't see that the mechanism of action of marijuana is something sustainable. They usually just develop a habit to it and become actually worse off overall. Another one that a lot of people are overhyping are psychedelics, things like psilocybin and LSD. Yes, there is new research talking about how these medicines or these narcotics, these derivatives, can be used effectively for things like serious trauma. But we do not see a lot of evidence, at least longitudinally at this point, that it should be used for depression. And again, unfortunately, a lot of people have heard the hype, heard popular voices talking about it, heard anecdotes about it, and they're going out there trying to get high on this stuff, believing that it will just evaporate their depression and they'll be better off and have some kind of epiphany. Lastly, another one that we hear about sometimes is MDMA or ecstasy. Again, these are all just street drugs. Ecstasy is a party drug. It gets you high, and a lot of people will say, wow, I took ecstasy and I didn't feel depression. Well, no joke. You take ecstasy, you don't feel anything at all. It's just a huge dump of dopamine and euphoria. But again, you're burning out receptors, and long term, it's not going to be something that delivers you from chronic depression. One of the big tests of any medicine that these three individual medicines or substances fail is that a medicine should improve your functioning. Yes, it should attack your symptoms and improve your suffering, but it also shouldn't subtract from your ability to function, like drive a car, parent your kids, or go to work. Obviously, all three of these substances subtract from your ability to function. They are overhyped, they are not medicines, and at this point, they do not have strong evidence bases to substantiate their use. As we get to the end of this conversation about antidepressants, I just want to remind you of a few things. People that are taking antidepressants are usually depressed, and one of the things that they're struggling with is patience and abilities to remain consistent. You need to keep in mind that most antidepressants take 1 to 4 weeks to start being effective, and so you're going to have to coach and support your patients so that they can maintain medical compliance until the medicines can reach that therapeutic dose. Depressed patients often struggle with doing the right thing and staying encouraged, so you're going to have to be that voice that's supporting them and carrying them over the finish line. And the last thing I want you to keep in mind is that people that are depressed often self-medicate. They abuse things like alcohol, marijuana, narcotics, and other medicines that can complicate the work that the medicine they're supposed to be taking is doing. You'll have a lot of patients that'll say, I don't know why these antidepressants aren't working. I've been taking them for 2 months, and I'm also smoking marijuana 8 times a day, or I'm drinking a 6-pack every hour. When you hear about these complicating circumstances of narcotics or other psychostimulants, you have to help educate them that those things are counteracting the medicines they're meant to take and maybe nullifying the results. In this series, we're covering the most common forms of medicine and mental health to help therapists feel confident and familiar with their work. I hope you'll use these videos as a resource for yourself or your colleagues, and I look forward to sharing more with you in the future.